Good morning, everybody. Thanks so much for joining us this morning. We are working on getting everybody from the waiting room into the webinar presentation. So take this minute or two to grab yourself another coffee, and we will get started in the next couple of minutes. Morning, everyone. For those of you that are just joining, we are just moving people from our kind of virtual waiting room into our presentation mode. So planning on getting started in another minute or two. So thanks so much for your patience. Okay, I think it's 9:03. I'm mindful of respecting people's time this morning. So I think we're going to get started. A couple of housekeeping items before we begin. This session is being recorded, so we will share the link with everybody, and we'll also be providing it through our broader OHA communication channels. I would also encourage you to use the chat function throughout if you have questions or points of clarification. I will be monitoring that throughout, and we'll be engaging with our speakers a little bit later on in the presentation to try to answer some of those questions. So with all of that being said, I'm Melissa Prokopi. I'm the Director of Legal Policy and Professional Issues here at the Ontario Hospital Association. And I just want to say before we get started, thanks to all of you. I know it's a really trying time for everybody right now in healthcare, and really appreciate all that each of you at your various organizations are contributing to the fight against COVID. So really happy to welcome you today for a discussion on how the healthcare sector can really leverage the support of the Ontario Chamber of Commerce's Ontario Vaccine Support Council, both to enhance current opportunities and create more efficient vaccination clinics. And with the support of these businesses and a number of volunteers from the community, hospitals together with their local public health units may be able to consider some really creative solutions to vaccine delivery, including leveraging local public health spaces, mobile vaccine units, and even pop-up clinics. So really the art of the possible here. And I have really privileged today to introduce to you Dr. Ian Era. Dr. Era is the Medical Officer of Health and Chief Executive Officer of Grey Bruce Health Unit. He's the visionary behind this model and designed and implemented the Hockey Hub model for vaccination clinics, and he's going to speak to you about that today. We also will hear from Rocco Rossi, who's the president and CEO of the Ontario Chamber of Commerce, and he's going to speak about the Vaccination Support Council and the various supports that they can offer to organizations. And I would also just say that we have Rick McMurray. Rick has been the setup lead for mass immunization hubs, and he's also the manager at Bruce Power. It's his day job, and he's also on the line here with us. So if there are specific questions and insights around kind of the operations and logistics piece, Rick is also here to help us answer some questions. So with all that being said, I'm going to turn it over to you, Dr. Era, to walk us through the Hockey Hub model. Oh, you're on mute.
Thank you, Melissa. Thank you, everybody, for your interest. Here is the presenter disclosure. The College of Physicians requires us to disclose. I don't have grants, research. The private sector does not know I exist from funding point of view. Overview of the presentation. It's around 20 slides, maybe 15 content. Underlying principles of the system, prerequisites for it, the competitive advantage, the advantages over the traditional system, and operational utility, strategic utility could be another layer to it. I can take questions on it. It probably would be useful if the audience was interested in it. Paradigm shift. Anytime there is a change in the need in the phenomenon we're dealing with, whether it is a pandemic or any other situation, sometimes the solution is to turn things upside down, sometimes to replace it completely. And thinking out of the box is not something usually happens in medicine. We're trained to follow certain procedures for very good reason. And you look at the traditional model, clinics are designed for many things, not just for immunization. Definitely, they're not designed for mass immunization. For mass immunization, for the act of providing vaccine, you need very simple tasks, whether it's registration, documentation, the controlled act of injection under the dermis, which is something should be done by a healthcare provider who's licensed to do that. You can see from this graph, just a traditional clinic, there are many, many things in that clinic to do many other functions. And if we're going to be giving the vaccine for hundreds and thousands of people, many of these things will get in the way. You can see here 3 dots. It's going to come handy later in realizing a person would register and wait. Then when the healthcare provider is ready for them to receive the vaccine, they will make another trip and wait and get the vaccine, then wait for recovery. And this last trip usually is associated with a higher risk of vagal reflex. People just faint for no good reason. It's not pain, it's not fear. And you can see an injury. I remember in my first time in a vaccine clinic as a medical student, somebody injured themselves. There was a gush of blood. The whole clinic stops. Drastic situation. The EMS to go in and out is an issue as well if there is an allergic reaction or injury. So if you take all these barriers, you end up with a flow that is free, completely a process that's designed for vaccines. This is a standard arena, and the metrics are very related to real measures. You would see that the process of vaccine here, and I'm going to break it probably, it's easier to go to the next slide and come back to this one. So bear with me. I'm not going to flip much, but this one is a useful slide. The orange section is the controlled act. It's a clinical task. Most of the tasks that we do in clinics are not clinical, whether cleaning the chair, flipping the computer open, directing people. Registration could be done by non-clinical. So if we separate the two and break down the process to half a minute, whether it's screening at the front door or walking through the parking lot, and assign these tasks to people, multiple people, and people who are not healthcare workers, we can ensure that there is efficiency in preserving the skilled workers in the setting that are most needed. And in a pandemic, I much rather see a physician or a nurse in OR or in ER or in the ICU instead of spending 15 minutes to give a shot of vaccine that can be done, most of these tasks, by somebody else. So if I go back here, a person would register online, would arrive at specific time, and the higher the numbers, the more specific it has to be. We can vaccinate in a standard arena 4,500 effortlessly per day, per 10 hours. And the unique part of this design, it can be done with 5 vaccinators. So a person would vaccinate 900 people per day. And it is quite doable. And we have executed it last week with 3,500. We didn't want to go to the max just to have a blackout period in the middle to manage. So a person would walk in, register, and in the earlier model, we needed all these tables to keep up with registration. Now we moved to actually scanning the health card. So we were piloting scanners. So the person would just put it there for 30 seconds, take out around 3 minutes of the process, and all the chit chat and potential errors in data entry. They will proceed here. This is not a waiting area, rather just a buffering area in case things slow down here for any reason. And there are 3 meters between these two individuals. The flow will be around, this is 30, and the number 30 is based on the 15-minute recovery period. This is a hard barrier none of us wanted to cross. A person would sit there for 15 minutes, and if we're vaccinating people within 30 seconds, you can do the math. A person can start vaccinating, going around and finishing in 15 minutes, and they can vaccinate 30 people. So that's where the number 30, that line, and those lines are assigned a certain number of staff, usually one nurse and a runner, a person pushing a table. It could be 2 nurses. The efficiency is the same. We ran different models, and both of them checked out the same speed. There is utility in having 2 nurses to switch roles every 2 hours or so. The person will sit. They'll get the injection. The unit of 2 people would move around, and by the time they're done, this person is ready to go. There is a person who would be patrolling these aisles. We have our EMS volunteering in the hubs to ensure safety and to ensure if somebody needs any help, or in case if there is allergic reaction. By the end of the 15 minutes, a person will check them out and they would leave. There is another model where they will see the person in front of them leaving, and in 30 seconds they will leave. In arenas, there are clocks usually on walls, so people would see the time too. In the cubicle itself, there is, during the waiting period, there are certain messaging on posters, whether it is to take a selfie and encourage other people to get the vaccine, or to fill a survey, and those results will come later in the presentation. There is a recovery area for anybody who needs that level of care. It's enclosed and private. There is a Zamboni room where an ambulance is ready to be in action, but out of sight. As you know, those things can, the presence of an ambulance can increase anxiety. So the Zamboni room is a perfect location for it. There is a desk for people who need the receipt. Most people would receive the receipt through COVAX electronically by email. For people who don't use email, we can print it out here. We can print it at a later date or time. So this is a process in general, and the recovery 15 minutes. The consent in the injection is 30 seconds. And that was one of the things that required a lot of change management. This item here, prerequisite, change management to actually go through with the team to change a practice of years or training for years to convince them that, yes, we usually establish the rapport with the patient and the patient-physician or clinical relationship. Nevertheless, the goal here is completely different, is to provide the service and move to the next person. And it is a soft barrier, but requires addressing early on in the process, whether on the clinical level, the staff, or the non-clinical. Communication is, too much of it is not enough in emergency. It's a cornerstone on all levels. And in a certain project, if you want to change the practice that people had for years, you require communication. For the public themselves arriving to this machine, more or less, it operates in a different way that the clinic would operate. We had, with the help of Bruce Power did a tremendous amount of work providing support, whether providing the equipment in the arenas, and I will go through that a bit after. But one of them is an app, developing an app that will provide information about the process. We wanted to produce a video and walk people through, just to walk through 2 minutes, and I believe it was distributed before the session. Optimal collaboration among partners. Municipality offered the arenas, public health is leading this, designing this, the police, the traffic in the area would have to be altered for operation for full capacity. EMS, and again, as I mentioned, the largest nuclear reactor in the world happened to be in our backyard here, and they have been indispensable in the response to COVID, whether in providing masks early on, providing hand sanitizer for not just for Grey Bruce, for the whole distribution to the rest of the province as well. Limitations, the parking capacity is the only limitation. We can go up to 10,000 per arena, but the parking will be a limit around the 5,000. That's where we set it around 4,500. Road access in the town needs to be altered. As I mentioned, reaction time is 2 days. We started by 6 days to get people to be ready and all these things. Now if we receive a shipment within 2 days, we can activate it. Similar probably, or as good as any other smaller clinic. Booking system compatibility is a barrier. The booking system provincially has a limit of 2,000, so we had to do certain things locally. This is another system affiliated with that system, with the hub, to ensure how can we book. Intervals of 10 minutes is not as sufficient. The interval could be 1 minute or 3 minutes or 2 minutes, depending on how many lines we operate in the hub. And we have 3 hubs. One of them is 5 lines. The other one, the Davidson Center, 3 Bayshore. So it is some of the virtues of the system. This is a snapshot from the video that was produced on the process to show the public how it works. And you can see the cubicle, and that will come in the efficiency. Usually any cubicle in mass immunization would have 2 chairs and a table and a computer and some other items similar what this table has. In this case, it's just a chair, as simple as it gets. The simpler, the better. And there is an iPad there, the registration, the consent, and the injection all would happen in 30 seconds. The recovery, the person would be just checking on the patient over the 15 minutes. And you can see the time there. Everybody would know you start now, in 15 minutes leave. If not, the person in front of you. So we assign volunteers on the floor, and the further we work with the system, the more we know that we don't need as many. The process would flow on itself, on its own. Competitive advantage, this is the meat of it. Patient-centered care, literally centered. This is, the patient arriving, sitting there, all the service would come to them, the recovery would come to them, they would leave. And safety, there is no vagal reflex. A person is not getting up and leaving and falling and injuring their head or injuring their body. Efficiency, no need for prioritization. If we have, the task this week is, should we give the vaccine to teachers or childcare or shelters? We can vaccinate all of them in 1 day. There is no need to priority within the school itself, a task that takes sometimes weeks. Who would get first, and the equity issue of it. Physical resources, as I mentioned, instead of having 150 computers, 1 in each station or a cubicle, we have 1 rotating, we have 1 table rotating, we have half the chairs, 50% of the chairs, instead of 2 chairs in each cubicle, there is 1. So resources, it is tremendously cost saving. Minimal need for clinical staff. That's the main benefit. In Grey Bruce, we are in a 3rd wave, and I need to assign staff to contact tracing. We have a shipment of 5,000. We can execute it in 10 hours by 15 staff, and we go back to doing our work. Similarly, in a hospital, you can assign people to the emergency department instead of sending people to mass immunization. Decreased cleaning requirement, it's 1 surface to clean, not multiple. Scalable, it could be a small arena, big arena, it could be a community center, 2 lines. If you take the equation with 1 line, it will check out all the time, so you can plan accordingly. Accessibility, most of us Canadians live in close proximity to arenas. They are ubiquitous. Low reaction time, again, that was a barrier, now it is 2 days. We get the heads up of pivoting, and we can change our plans overnight. Quality of care is a virtue, definitely. Lower risk of fall, fast access to EMS, less risk of transmission of COVID. The narrow window of time, 15 minutes in a clinic instead of being an hour and a half or an hour in a clinic, that's risk for exposure. One-way flow. You'd see people in zigzagging sometimes in waiting areas, and anytime a person coming face to face with another person, there is increased risk here. It is one-way direction. Better air circulation arenas. In 2014, I think in Ontario, there was an issue with Zamboni exhaust. So it's even better ventilation than many people think there, let alone the bigger space. Survey results, patient satisfaction. I worked in research for years, never seen a survey 100% or 99% satisfaction. The rapport was established with a patient. I had the anecdotal or qualitative survey after the first run, and I was pleasantly surprised that the patient felt they were connected. So our staff have the ability to shorten the period, but still establish that eye contact and care and the gestures that the healthcare provider builds their trust through to provide service, healthcare provider satisfaction. There is sense of industry in the staff, fulfillment, enjoying switching tasks. You know, a person would be injecting for 2 hours, then taking consent for 2 hours. Simple task, straightforward. I was worried about repetitive task being boring. It didn't turn to be. Nevertheless, you can appreciate these hubs, if they operate for 15 days, they will vaccinate all the 150,000 people in Grey Bruce, and we'll be done. So we're not operating for weeks at end for repetitive injury or occupational medicine. Comparing standard model, large model, mass immunization clinics with this model, my understanding around 2000 would require 17 to 20 vaccinators. We're doing it with 5. All the other healthcare workers can do what is most needed in hospitals. There is more volunteers than non-clinical tasks, whether door screener or cleaner or navigator on the floor. These numbers are way less right now. You add them up, they're around 30 to 40, depending on length of operation. And these numbers are for 3 hubs in Grey Bruce. This number here, lower right corner, I'm getting close to the end of the presentation. This is the number of days required for 2 complete dose for all the 140,000 eligible people in Grey Bruce to reach herd immunity. If we are given the supply of vaccine that's sufficient. This was calculated after the fact. Efficiency financially is not a virtue in emergency management. Redundancy is a virtue. We spend more for good reasons. Nevertheless, it is way less cost comparing to the traditional model. Utility, this is, you can utilize this model for many reasons. One of them is allocating full complement to what you usually do in the hospital, minimize need for prioritization. I mentioned that. Minimize the need for planning. Overnight, we can switch from this number to this number when the pivot happened with the 60 plus last Tuesday. Indispensable when we have large shipments. And that's my family. When we were introducing the mask to my daughter, and she was excited about it for 2 minutes, then you would find it on the floor or anywhere except the face. And we hope this situation will resolve very soon. I do believe this system is another tool, maybe a hammer to put the last nail in the coffin of this pandemic. Open to questions as always. Thank you for the opportunity.
So thank you so much, Dr. Era. I will say I have seen this presentation kind of in advance of this, but listening to you walk through it, and there are some questions and I want to keep those till after we hear from Rocco, but I made a couple of notes to myself, particularly when you showed the kind of the flow slide, and you made the point that most of the tasks we do in clinics are non-clinical. And we're hearing a lot right now about shortages of HHR and burnout. And so I think, like, your point, and I wrote it down, preserving skilled individuals to do the jobs that we need them to do, I think is so critical. And I will also just say, because you didn't say it, for those of you that don't know, that Dr. Ara's clinic did the most number of vaccinations in one day across Canada. And I think that's a testament to how efficient and effective and successful this model has been, and I think can continue to be. So I think there are some questions, but we are going to just wait a little bit till the end. And I'm pleased to introduce Rocco Rossi. So Rocco, over to you to talk about the Vaccination Support Council and the art of the possible.
Thanks so much, Melissa, and thanks to all who are on the call for all you're doing every day. My mom always wanted me to be a doctor. Sadly, I failed her on that, but delighted to get the opportunity to help the medical community through the OCC Council and phenomenal members like Bruce Power. It's not often that I disagree with Dr. Ara, but I have to disagree with something that he said when he started off and said the private sector doesn't know him at all, doesn't know his existence. That is clearly false. We are well aware, and that's why we were so incredibly excited to work with him and in Grey Bruce, because of his vision, one, and two, a willingness to partner, which is not something that necessarily comes naturally in the healthcare system. And totally understand there is no desire to subvert public health here. It is all about this is a we hope once in a lifetime experience, and we just are firm believers that it's all hands on deck. Full disclosure, of the over 250 members in the council, and those are businesses, colleges, universities, associations, and labor unions. There are several pharma companies, but anyone who is at all uncomfortable, they don't have to be the partner on what we're doing in your area, your clinic, your hospital, your PHU. All we want to say is, beyond the hockey hub, and Bruce Power very generously, along with other local partners, helped to fund the retrofitting on the doctor's design. And because of the word getting out, areas like Lambton heard about it. We received a call from Anita Tressler from Lambton, and from that first call, 10 days later in Point Edward, a hockey hub had been set up, been retrofitted. The team from Bruce Power, using the design that the doctor developed, went in, and local companies from Enbridge and others funded the entire project. And obviously, not everyone is going to want to redo hockey hubs everywhere. So what's important is that there are design elements, tips, tricks, really clever process that can be adapted to any clinic that you do have. And there, that IP, thanks to Ian and his team, is available to any and all to use. But over and above that, in terms of the art of the possible that Melissa mentioned, we don't want to limit your thinking to that. And what we've done in conversations that we've been having across the province is, what is it in your area that is the big bottleneck that can assist you in helping to accelerate vaccine rollout? So in Cornwall, Dr. Paul, as like to be referred, said, look, my issue is transportation. of people to and from their appointments. The government has put in funding now for seniors and disabled, but there are many low-income people that don't meet that requirement. We set up a fund with one of our partners in the local Chamber of Commerce in Cornwall and local cab companies to provide free rides to and from the vaccine appointments. In other places, it's facilities. And so Oxford donated the lease on the Scarborough Town Centre to the Toronto PHU to put up the mass vaccination site. In other areas, it's help with volunteers and managing volunteers. OPG assigned a full-time, recently retired HR executive to do nothing other than to help manage volunteer intake in Thunder Bay and the PHU. In other places, we're helping with transportation meals for staff and volunteers just to keep the process going. So there's a wide variety. We guess at some things, and in fact, we have a portal, vaccinesupportcouncil.com, where the companies have volunteered by PHU, but we're making guesses. And what we'd really love is a conversation with you, and we will partner you up with willing members of the council to assist. And a big issue that will come as supplies ramp up is also going to be around communication and hesitancy. And so there are many campaigns involved. There's communication, obviously. Our members represent over 1 million employees across the province. So getting clear messaging from trusted sources like yourselves, we want to help in whatever way we can on that front. So that's the sum of it.
Thank you so much, Rocco. I will just say personally, Rocco and I have been in touch daily, probably many times a day, trying to connect some of the willing businesses and individuals with the right receptors in various communities. And so I think I will just reinforce what Rocco said. I think really it is to support you in your communities with whatever your need is, whether it's from design and concept like Dr. Era's vision to operation, or something that is a bit more specific and nuanced, like transportation or volunteers, coordination, traffic,
or a mobile
units.
clinic.
I mean, there really are various opportunities available. So I would really encourage you to reach out to Rocco, or as he said, there are contacts on the Vaccination Council support page by region, and you can also reach out to myself directly and we can try to put you in touch with the right people. We have lots of questions coming in, Dr. Era. People are really interested on how you've made this work the way that you have. So maybe I'll ask, one is a bit of a technical question. So, and you might need to actually pull up one of your slides again. I'm going to put you on the spot here, but it says here in the diagram, there are 9 buffer lanes for 10 rows of seats. So does one row function differently? Is that a priority lane? I think people are just trying to understand the flow.
Certainly, if I may just make a couple quick comments.
Of course, absolutely.
To echo what you said at the last, Rocco, when I said the private sector doesn't know me, I added with financial support. So no grants, nothing here. I do believe in emergencies we need to pull on all the resources that we can pull. In Grey Bruce, Chapman's Ice Cream provided the vaccine fridge. It is vaccine, it's not ice cream fridge. I always get that question. We actually communicated with them in November. We inspect their freezers and we know they have the expertise in handling dry ice. So we had already planned a complete distribution system. Nevertheless, the plan came from the province that the shipments will arrive to the center. So there are multiple ways a person can, or an organization can utilize all the partners. Bruce Power set up 3 field hospitals in Grey Bruce. We designed it last March 2020. They were set up within 4 weeks maximum. So we didn't use them. They were our insurance policy. Luckily, we didn't have to use them. We decided to configure them as mass immunization hubs later this year or earlier this year. So there are many things that Bruce Power has been instrumental. I do believe public health does its best work when it mobilizes partners, utilizes the local capacity, and every hospital, every health unit has a different partners in the area, and they know their partners most. Chapman's and Bruce Power have been instrumental. My understanding from the executive in Bruce Power, the council that Traco is leading for the responsive vaccine was based on the experience that we had here. Nevertheless, I will go to the presentation as you requested. Is my presentation up now or not really?
Yeah, we were looking at your daughter there, the last slide. There we go.
Okay. So your question was about the flow.
Yeah, so the question was, it says in the diagram, there are 9 buffer lanes for 10 rows of seats. Does one lane function differently, a priority lane?
We thought about priority lane, but no, there is no difference there. People would just proceed. Usually this area is not packed. It could be packed at certain times, but most people would just scan and walk in and find a seat immediately. There are navigators here who can direct people depending on the need. Here it might be busy, but in an arena and there's a lot of space, a person walking from here would know exactly where to go. It just all the floor has arrows, and the volunteers again would help if need be.
Okay, that's helpful. So question about the preloading of vaccines. And I don't think you mentioned this during your presentation, but someone shared that it takes between 1.5 and 3 minutes, depending on the vaccine type and the staff skills. So someone wants to know how you're kind of managing this process step.
They're all loaded in a different room in the facility. In arenas, there is a room for staff to rest. There's a room for vaccine constitution. And that's where for each vaccinator here, there will be 1 or 2 people preparing the vaccine. The vaccine will be set up on a tray of 30 doses on a tray, and it will be pushed through this door, the staff door, and will be given to the next team who's going to go around. So the process keeps going, and more trays would come at the end of the 15 minutes.
So lots of questions about consent. I think people are really interested to know, one question here says, how are you obtaining consent so quickly? And then a similar question, can you provide more detail about what each of the 2 nurses is doing? So who does the assessment, the clinical assessment, who's doing the consent? I think everyone's interested to know how you're getting it done so quickly.
So we do consent on different stages, similar to vaccination of students in schools. The parent would receive a letter of consent. They will sign it a week before. So when a person goes to online to book their appointment, there is enough information on our booking system, local booking system and website, including the consent and the process and all this information. So they will review the consent there. When they arrive at registration, they will be asked to go through the consent in some detail. And they will ask, if they have gone through it in details, and if they have any questions, they will sign, then they will proceed. So at the injection site, the consent is very minimal, down to, have you read the consent? Have you any concern? Are you able to get the vaccine based on it? And if the answer is yes, they will proceed with injection. So it's all set up pre this stage of injection.
Question about monitoring of individuals. So you mentioned that the nurses move on to the next vaccination pod. So can you just go over again, who's actually monitoring these individuals after the vaccinations have been received?
So we have staff who are going around, and including EMS. There are volunteer physicians, sometimes volunteer nurses, retired. So that's during the recovery. There is a period of monitoring. And we started with heavy number of people there, and we end up with 2 EMS can actually monitor this whole area. There was a model where we had 2 or 4 observers, where the audience sits in a arena to observe if somebody's in distress or not. We soon realized that there's no need for it. People on the floor can actually make sure everybody's taken care of.
A couple questions about the transportation of vaccines. So, I mean, you talked about storage and leveraging Chapman's freezer, but question is, what are the vaccines that are being used, and are there any issues with transportation? I guess this individual has some instruction about walking it over versus driving it, and kind of how long it can be out of kind of refrigeration, kind of freezer.
So we have 3 locations. One of them has a freezer that we haven't used. The freezers in the health unit, we don't have that many shipments. They don't sit much in the freezer, but we transport the vaccine over a trip of 1 hour between Owen Sound and Hanover, and we use the vaccine at that time at that location. As you know, after taking it off the freezer, room temperature, it must be used. There is more flexibility with moving the vaccine right now. This design was in December, when we were under the impression you cannot.
This is for Pfizer, correct?
Correct.
Yeah.
So it was designed to bring people to the arena, not move the vaccine whatsoever. And that's where we designed to have a freezer within the arena itself, one of them. We never had to use it after the loosening of restrictions on moving the vaccine.
So, question about the actual cubicles themselves. So someone wants to know, were they built or built locally or bought off the shelf, and where can they get their hands on those?
So they were donated by Bruce Power March 2020. They were not in this shape. They were donated for a field hospital, bigger cubicles, and each cubicle would have a bed and a chair and some type of lamp. When we came to the stage of there is vaccine, we converted these facilities to this. Again, regular dividers, there is nothing magical about them.
I know when I chatted with Rick from Bruce Power that, as you said, it was regular dividers, getting the fasteners and the kind of components and standing it up in a way that operationalized the design and vision that you had. So it sounds like these are things that can be purchased in every community.
Correct.
So a question about COVAX and the COVAX system. Actually, before I go on, Rick, is there anything you want to add to that? I just noticed you clicked on, so I don't want to. Is there any insights you have on the supply side? I think that would be helpful.
Yeah, just a point of interest. They're bought through Trustcore over in Palmerston. We have bought a lot more this year as well. They are in tight supply, but we are in their queue to get them as fast as we can if we need them. They can produce them pretty quickly on site there. They all come with their own hardware, so you'd want the hardware to come with them, and they're very good for this application. We actually have a setup with them that we can get them at wholesale, which is about 30% less, that you'd pick them up off the shelf.
That's great. So we'll make sure, Rick, that your contact information for those that are looking for the wholesale value of these types of supplies. This is a good opportunity to connect with Rick from Bruce Power to be able to do that.
Sure, happy to help.
Thank you so much.
And we're happy to help through the council.
Absolutely.
In the funding of those and using the buying power that Bruce has developed for the council. That's
very generous, Rocco. Question about COVAX. And I mean, I know COVAX has been challenging for many. So the question really relates to kind of, data entry and how you're able to kind of keep up with the kind of inputting of information into the system with the speed at which you're completing vaccination. So how do you account for when an individual's record is, with glitchy, or the system slows, or there's, freezes? I mean, there's always issues with, inputting information or not having full information. So I think there's just a question on how do you keep that flow moving? And I've heard this in lots of different scenarios, is sometimes COVAX is a bit of a limiting factor just to keep things moving.
Definitely, these are issues that we experienced. Having the scanners would really reduce errors in entry and reduce the time of entry. Nevertheless, we have IT on site. If there is any issue there with IT, support would be available at the registration desk here. That's where the registration is completed. If we have curated lists or the data was entered through our booking system ahead of time, that will make it easier for registration. At the injection location, there is a quick verification of the name. So COVAX, my understanding when I was on the floor with the team, has 3 screens. The first one, you enter the name, you ask them about their name, date of birth, and you click next. Then there is a list of questions. If all of them are no symptoms, no issues, that's part of the consent, you can click the last one and say no, and all of them will be generating no. So again, that's like 2 seconds. And the third one is for the check after recovery. So again, we've experienced these issues. Sometimes they slow the process, but having the right people on site, having the communication tools, there's walkie-talkie with the nurses on the floor, with the IT on the location, but they could be in other room. So there is always that immediate support for people.
So so that's actually really helpful. And I know, the process of the COVAX interface, I know, has been challenging. So just so that it's clear, and I think on the sort of side of the screen where you have the registration, that's sort of where the history is being taken of the client, as you said. So it may be uploaded into already based on pre-registration, but the questions about, whether they've had a vaccine, if they're pregnant, do they have any immunity, any compromised immunity conditions, et cetera, that's all done before they get to the immunizer, I guess, is the question that's being asked. And is that being entered into COVAX through the registration volunteers? I think people are just trying to understand how it interfaces with the existing system.
It is entered at the registration at this desk. And if somebody requires that level of care or level of consent, usually the hub is not the best place for them. So when people go on our website, we read the process, and it's very clear that if you're ready to get the vaccine, just come over. If not, see your healthcare provider.
I'm mindful of time. I've got a couple more questions here. Another question around preloading. So how many preloaders support this model? And I guess the question is, does preloading start prior to the clinic starting? And if so, how far before?
It starts before the clinic starts. We usually arrive around an hour and a half beforehand to ensure all the operations are clear. We have multiple volunteers. We started a list of volunteers last November that's still growing until now. So you can appreciate anytime we're meeting, there are members of the team who've never been in this process before. So we give ourselves an hour and a half, sometimes 2 hours. The ratio of nursing really changes. Some of our volunteers are nursing students, some of them retired nurses. So the difference in experience can change that ratio, but usually it's 1-to-1 or 1-to-2.
Okay. And for anyone that needs observation for more than 30 minutes, are they assigned to a different observation area, or do they go within that larger observation area that you pointed out?
They could be recovering here in this area. Okay. The flow should be calculated in a way there is no slowing, like 30 seconds. When we go with the 80+ group, you can appreciate sometimes they have hearing barrier, so the registration might take a bit longer, the consent might take a bit longer. So it will be around a minute. But in general, if we're running the hub, we don't want somebody to stay there for 15 extra minutes. That's a lot of time to change the process.
Another question, I'm just looking here. I want to make sure we've captured all of these questions that are coming in. A question about how you handle leftover vaccines. Great question, because I know that, I mean, we were talking earlier about just being available and having people kind of ready and willing to kind of come at a moment's notice. So I'm wondering how you manage that based on registrations. I think it's always a challenging issue given sometimes where we are with precarious supply.
Definitely. All these questions are really not different from regular running of a clinic. There are different strategies. One of them that we use here is to have a list of people available for short notice to arrive. The volunteers on site were definitely a plus at that time because they will be coming again. So having them vaccinated is something we can all benefit from. Slowing the process of reopening new vials for the last hour has been the most effective. So, at the clinics closing at 6, around 5, we ask the clinical lead to be looking at the number of vaccines drawn and just slowing that process down. It hasn't been an issue. The number of waste vaccine when we reached the 20,000 doses have been around 30 doses. So it's very minimal.
So another question about the booking system. So if you're doing more than 60 appointments in an hour, so are appointments times down to the minute, or how are you ensuring that you're, keeping kind of things moving along that time frame?
That's one of the soft barrier we had. The provincial booking system does not allow for less than 5-minute appointment. So we just adjust for it by increasing the number of people attending the appointment. So it will be, I think that's the slide I had here. So for vaccinating 2,000 people in 2 lines out of the equation, we need this number of people to go through 6 minutes. That's 5 minutes. So there are certain calculations for it. Our Excel sheet will do it automatically, but mainly increasing the number of people in a time slot.
Okay, that's helpful. And question, yes, this presentation is going to be shared as well as the recording of the actual session. So that will be available to participants to share with colleagues and others after the presentation. Maybe I'll just ask Dr. Era, I don't see a couple more questions coming in, but reflecting on kind of the success of this, what would you say would be kind of the biggest learning from kind of initial vision to kind of operation? And you talked a lot about processes changing as you learn more and learn how to be more efficient with staffing or other processes. But if you had one kind of anecdote or take-home message for the audience, what would you say to them?
Engaging the frontline staff in the process of change. Medicine has been established for years and years, and we talk about patient-centered care. Nevertheless, our system is physician-centered. We go to cardiology to see the cardiologist. We go to radiology to see the others. So in just engaging people in the process, explaining that, yes, we are going to be moving to serve the patient, and that's a change in process. That buy-in from the frontline staff, from the managers, is tremendous. There's always a tendency for the team to slow down or go back to the traditional model for the first period of time, and as soon as they see it in action, it is definitely supported by everybody. So if I would do it again, I'll just engage the team a bit more earlier on. I communicate with managers, not for the frontline staff, and I will do it the other way.
So one last question before I wrap up. So how do you manage clients who don't have email or English as a second language? Is there kind of health history and consent? Is it done at registration the same way, or do you do it separately with a nurse?
Yeah, at registration is the best place for it. As soon as a person enters the system on these lines, there shouldn't be any slowing down there. And if there is need for anything, we can definitely have the volunteers help the person back through the process.
Okay. Well, I just want to say huge thanks, Dr. Era, to you and to this vision and being willing to share it with the OHA, and to Bruce Power for their support in being able to operationalize all of this for Great Bruce, and Rocco, to you and to your members and to the businesses that are being so generous with time and resources and staff. I think, Dr. Era, you said it well. We're at a time where we need all hands on deck, and everybody needs to come together in the best way that we can. And so I think I would really encourage all of you to check out, I put the link in the chat for the Vaccine Support Council. And if there are specific questions that you have for Rocco or for any of those businesses, feel free to reach out. I know Rocco is always very responsive. And if you have questions specifically for Dr. Era about this model, his contact information, I believe, will be shared as well. And you can also connect directly with me, and I'm happy to make that connection. So thanks again, everybody. I really appreciate you sharing your time with us today, and stay safe and try to get some sunshine. Take care, everyone.